and translatable data and evidence is very important in this field, which is in some way on shaky ground in terms of funding in the humanitarian sector, in terms of evidence, in terms of people's commitment to these type of activities in humanitarian contexts. So an MHPSS expert from one of UNHCR's implementing partners said, donors are always saying, what about the outcomes? Mental health is not like vaccination, where one child is vaccinated and they're okay. So I think one of the reasons that organisations and donors stay away from mental health is because they feel like they can't measure it and they can't pin it down. So I think we have an even bigger responsibility to really show impact. So I wanted to note that the lack of evidence is also not only perceived that the evidence doesn't exist yet, but actually that there is just no evidence that these activities actually work. And so it means that when people are trying to justify these activities at a budget meeting and funding crisis, they're often coming up against this resistance that these activities might be useful or, nice if we had endless money, but they're really a luxury that aren't really necessary in these settings. So someone from UNHCR headquarters noted, we really need to get clear indicators and clear expected outcomes so we can say it's more visible, it's more tangible, and colleagues will say, yes, that's important. They would then understand better what it means concretely and what the impact is on refugees. If you're going to put these programs on solid footing within UNHCR, we're going to need some way of defending it through proper evidence and evaluation. And he went on to discuss being at budget meetings where people are saying, well, I can prove what the evidence is of food distribution, of handing out blankets, of handing out jerry cans, and you can't show me what happened from that art therapy activity. So it's really a question of support and commitment to these issues. And so that brings me to the question of what should constitute evidence in this field. And at first glance, that's a pointless question. Evidence is evidence. In the field of public health, we have different standards of evidence, basic criteria as to the strength of different research design. The randomised control trial is at the top, and other quasi-experimental or observational studies are further down that list. But, for example, in this field, a recent systematic review of MHPSS activities for survivors of sexual and gender-based violence found 7 studies that would constitute evidence, none of them randomised control trials. So in that context, what should we say? There is no evidence? Does data need to be judged differently in that context where it's clear that there need to be programs and activities for survivors of sexual and gender-based violence? And how do we incorporate into our judgment of evidence the difficulty of generating data in these particular contexts? And I should note the guidelines are actually consensus-driven guidelines. They're not based on evidence. They're based on everyone getting together in a room, bringing forward their experience and generating consensus about what should be happening. So my argument here is that in a field with really a lack of grade 1 level evidence and data, what we should be saying is not just this evidence doesn't exist, but looking at questions of how feasible it is to generate this kind of evidence and whether the evidence that is generated is then translatable to a field setting. So here again we have this question of what are the important research questions that people are interested in. And interestingly, although a number of researchers and academics feel, okay, enough with the prevalence studies, there's been many prevalence studies in various settings, mostly they tell us X is related to Y, it's different in one context, it's different in another, but it doesn't necessarily really shift our understanding of MHPSS anymore. But what's interesting is that field workers report, and again in other research that Vitsatol has done here, but really report saying that that is an interest that they have in the field of what are the most important mental health and psychosocial issues. So what I want to illustrate here is my argument that what this is really talking about is the need to really shift from a sense of prevalence and epidemiological perspectives to a sense of a rigorous needs assessment. And what I think that can do is really open up 2 things. One, which is identifying the types of exposures and the types of outcomes that might not be usually included in a typical prevalence study that's seeking to identify mental health issues. And also that it can help to identify the types of interventions outside of the MHPSS sector that might influence MHPSS. So the first example is from a study that I did in a camp in Thailand, Burmese refugee children. And this was a study that was an open-ended qualitative approach to mental health and psychosocial issues. And at first glance, we sort of approached that seeing that the most important issues would be exposure to conflict and violence and the issues that generated the displacement. But that the data that was generated through free listing and through key informant interviews were really that what was needed to be focused on and what children reported as the most important issues were issues associated with the camp environment. Issues such as exposure to caregiver violence in the household, alcohol use, which was very prevalent in the camp, and forms of neglect that are quite nuanced in that caregivers are forced to leave their home for long hours or leave the camp to be able to earn enough money, and leaving children in situations that are dangerous or where they're responsible for other children. So that kind of nuanced approach really brought us towards understanding the camp environment more broadly as the toxic environment, which brings us to a whole other body of literature around influences on children's well-being. And so what my argument there is that when research is done from this more needs perspective driven approach, that what can be really incorporated in is the perspective of affected populations firstly, and can also lead us to this broader ecological view. Another study that I think did this very well, it was done by the International Medical Corps, which looked at the mental health and psychosocial needs of Syrian refugees in Zaatari camp in 2012 in Jordan. And so, again, approaching that from a perspective of an agency trying to develop MHPSS interventions, the main problems that came across were really issues with literally environment, heat, dust, electricity, the types of toilets and cleanliness, some security issues. And then again, so then what you have coming from that is that so many of the types of interventions they then recommended are things that were outside of the scope of the MHPSS sector, that came out to shelter, water and sanitation, some issues with health services, and approaching things such as, or suggesting things such as designing communal spaces to pray. And so this approach really allows, for an understanding of the ways in which MHPSS is implicated in other sectors in the humanitarian response, and the ways in which this type of needs assessment driven approach can allow us to develop those connections. So on to the second question here, and the question is then, linking to that first, is how can research inform interventions? And it's very clear that there's a mismatch between some of the most commonly evaluated interventions and some of the most commonly implemented. And it brings us back again to this question of the level of evidence. If you're trying to conduct a randomised control trial, and that's the gold standard of research methodologies, the types of interventions that most easily lend themselves to conducting a high-quality randomised control trial are interventions that have very clear manuals, a very clear step-by-step implementation, often counselling sessions, 12-week individual therapy or group therapy, and are much, much harder to implement, to evaluate in this type of way is something that's a more diffuse, community-based psychosocial activity where one person might be exposed to 3 different sessions and one person might have gone to a child-friendly space. So those types of activities that are very prevalent in the field are very difficult to capture in this type of approach. So you really start to see this mismatch between what's happening in fieldwork and activities and what's being evaluated and the types of research methodologies using this. And the final point here as well is that research needs to address not just what types of interventions work, but also how they work, and what types of things are needed in order to put together a 12-week clinical intervention in terms of training, capacity building, and support. So one example of what I think has been a really interesting approach to addressing this question is a research partnership between Columbia University and World Vision that has identified as a very commonly implemented intervention as child-friendly spaces. So those are spaces that are set up often in displacement settings that seek to provide physical protection for children and also improve psychosocial well-being. They might have informal education or play activities, but that they've been very difficult to evaluate. There's often no baseline data. It's difficult to see which children have been exposed to the child-friendly space and not. But that this partnership has really been brought together in order to, they've identified this need to generate evidence, but have created research methodologies with this direct link to practice and to implementation. So this really addresses what I would call the norm of off-the-shelf interventions. So the reason that a child-friendly space is quite commonly implemented is it's quite simple. There actually is a step-by-step guide for it. It's low resource. It's something that doesn't really require immense skills from a field worker or very specialised skills, and it's something that people have come across in the field. So a field worker from Sri Lanka has implemented a child-friendly space and is now working in Sudan and is likely to also literally, take that off the shelf and implement that. So although that might be something that's a bit anathema to researchers or academics who would want the type of intervention to be selected based on rigorous assessment of needs or the highest quality of intervention, I think what is needed here is at least recognition that this is how this is working in the humanitarian sector and working within this framework to some degree. So I think that this is what this partnership really illustrates, is saying, okay, this is a very prevalent and very common intervention, and we would like to inject into this intervention more rigour and more structured and systematic understanding of how these programs work in order to also improve them, because there is very wide variety of quality of child-friendly spaces. So then my third and final question here, just to start wrapping up, is how do the fields of MHPSS and global mental health relate to each other? So it's very clear that the IASC guidelines are developed for emergency settings, but at the same time, the humanitarian sector and humanitarian context are much broader than just acute emergencies. So you have MHPSS activities and programs and approaches in a refugee camp in Kenya that's been in that context for 20 years. So there's a sense that although it's an approach towards an emergency setting, that there's a broader relevance to long-term humanitarian settings. And there's quite a lot of thinking around how to adapt MHPSS, say, to urban settings that's going on right now. So my question here then is, what is considered a humanitarian setting and why is that relevant for MHPSS? And the two things I would think through here are the question of systems. In a humanitarian context, you often have a great breakdown of systems. The government is no longer capable or willing to provide services to its population who may or may not have already been displaced from its territory. You have international agencies stepping in, setting up sometimes parallel systems, but providing services in that way. So you have a particular setup of systems that is something that is quite distinct to humanitarian settings. And you also really have a particular set of vulnerabilities that are around marginalisation, that are around breakdown of coping mechanisms and social support that are considered distinct to humanitarian settings, and that while they may occur at a point of emergency, they can be very ongoing. So from the example in this refugee camp in Thailand that has been there for 15 years, you see ongoing and very chronic intergenerational issues. So it's not just about the particular emergency context, but that's ongoing. But so my argument here that I want to illustrate just briefly with my work on the Thailand-Burma border is that this might actually be the case, this question of systems and this question of vulnerability, for extremely marginalised groups in low resource settings. And so we might need to think about broadening the sense of MHPSS and integrating it further into the broader community of global mental health and that movement for mental health. So this is really the norm in low resource settings where there are marginalised populations who might not be considered as requiring protection from the humanitarian community or as in that particular context of a humanitarian setting, but these same issues still apply, and there is particular learning that we can take from the field of MHPSS to apply to these settings. So the work that I'm doing now is in a town called Mae Sot on the Thailand-Burma border. This is considered a humanitarian setting for the past 20 years. There are 9 refugee camps along the border. Everyone in those refugee camps is considered a refugee who has been affected by humanitarian crisis, and there is protracted displacement in that setting. But the major population that I've been doing work with in Mae Sot is actually labour migrants from Burma who have come to Thailand for a range of different reasons, primarily economic and some social and political reasons, and who are not considered affected by a humanitarian crisis or considered as a part of the population that requires special attention by the humanitarian community or special services for those reasons. But my argument from my research is really that the same issues of marginalisation, the same issues of systems really affect this population to the degree that I think there needs to be some rethinking of the divide between MHPSS and the broader sense of global mental health. So they're migrants who are mainly unregistered, undocumented, and often fear arrest and deportation and live with chronic stress around that. Our data, we did 61 qualitative interviews with migrant workers and just completed a survey of around 600 migrant workers using respondent-driven sampling to look at some of the mental health and psychosocial issues, as well as some of the exploitation and abuse that they're exposed to in this population. So there's really prevalent issues of forced work without pay, physical and sexual abuse in workplaces, not